We are now recording. All righty. Good morning, everybody. We're going to talk about cancer today. Now, I'm going to point out that we're not going to talk about particular types of cancer because, frankly, there's so many. There's a multitude of cancers out there, but they all follow basically the same pattern. We'll hit on a couple of them as we go through. But we'll get into that as we go along here. But we're going to mostly talk about what is cancer, what type of diagnoses we use for it, and what kind of tests we use. And then, of course, the nursing interventions that we would use for the cancers. And we'll just kind of touch on them as we go through. Each and every cancer in and of it by itself is an entire week's worth of study. And we simply don't have time for that. So let's just hit it from a real high level. First of all, what is cancer? Well, if you got into your Timby's book and you started reading about how the DNA split and RNA form to replicate the cell, and there's a certain section with a certain number that can be interfered with, so if the duplication process keeps going, it's quite complicated. In a nutshell, basically, a cancer cell is just a cell that grows uncontrolled. During the splitting of the DNA, one of the strands does get mutated and disturbed. And there are some precautions in our body and in our cells to try to stop that process, but sometimes that gets subverted. And then the cell will just continue to grow and grow and grow and grow, forming tumors. And often the cell growth can spread to the point to where the tumor will actually develop its own vascular system and feed off of the body's perfusion, becomes its own monster, so to speak. And these can appear anywhere. It can happen on the skin, in the lungs, in the liver, in the tissue, in the bone marrow. There's a variety of places that this can occur. But basically, cancer is just a cell that starts growing uncontrollably. Now, we're going to cover a couple terms here because you see these terms thrown around a lot. I mean, not just in medical circles, but just in the civilian world. I mean, cancer is the second leading cause of death in the United States, second only to heart disease. So probably every one of us has either had some form of cancer, known a family member who's had some form of cancer, who has a friend or associate that has had or has cancer. It's very common. Therefore, you'll see a lot of these terms thrown around in the media. Let's start with the first one, carcinomas. Carcinomas are epithelial cells. Those are superficial cells. Skin, the epithelium. Carcinomas infect the surface skin. Lymphomas. These are organs that are a part of your lymph system. So cancer that attacks your lymph system would be a lymphoma. And that's really bad because your lymph system is an entire circulatory system throughout your body, just like your bloodstream. So once you get cancer in the lymph system, it has a tendency to spread quite easily through your body. Leukemias, we've all heard of leukemia. Leukemia, basically, organs that form blood, that's your bone marrow. And leukemia is probably perhaps one of the deadliest cancers out there. And that's when the cancer starts forming in the actual bone marrow of the body. And there again, you're talking part of a circulatory system there, so it spreads easily. They say, once cancer reaches the blood organs like the bone marrow, where it reaches the lymph organs, the lymph nodes, that's really bad. Sarcomas, Sarcomas involve the connective tissue, bones, muscles, those types. Those aren't as common. But so you're going to see those terms thrown around a lot. So now you know what they're referring to when someone's talking about leukemia or the leukocytes. They're talking about the blood system. Lymphomas are talking about the lymph system. And these next two terms, I'm sure we've all heard about, benign and malignant. Benign is the good one. I mean, if they ever find a tumor on your lung or find a tumor in your brain or wherever, and they do a biopsy and they come back benign, that's when you go, whew, oh, good. A lot of people misunderstand benign to mean non-cancerous. Basically, it just means it's not as invasive as a malignant tumor. I mean, it's still a problem, but usually benign tumors, they can just cut them out and you don't have to worry about chemotherapy or anything of that nature. And they usually don't go systemic or what they call metastasize, which we'll talk about here in a little bit. So the benign tumors are the good ones. That's where everybody just breathes a big sigh of relief. Now, the bad news is the malignant tumors. The malignant tumors are the ones that grow rapidly and uncontrolled. They are very invasive. They infect nearby tissues. And they can affect fluid movement in and out of the cell. There again, these are the kind of tumors that will develop actual vascularity and actually feed off your body and just grow uncontrollably. So we all hear that a lot. We hear benign and malignant. Malignant, of course, is the bad one. Now here we get into the word I mentioned, metastasize or metastasis. Metastasis means that it has spread. They say here and in this definition, development of a secondary tumor, or basically it's spread into the lymph system or into the blood system. And that's usually very, very bad news. That's usually, that's when they start talking about how many months, how many years you got left to live. Now, there's different steps in this process. The initial process is that very first cancer cell when that forms. It's called the initial process. And this is when the cell DNA is damaged and that RNA develops in such a way that the cell just begins to replicate itself. Now, this is where you'll see the beginning of a tumor or a spot. As it begins to progress, it will mutate into other cellular populations within the body. But when it has actually invaded adjacent tissues or other areas of the body, for example, you have a brain tumor, starts in the brain, progresses there, but then it somehow ends up in the cerebral spinal fluid or moving over and getting into the bloodstream or the lymph system. Now it has metastasized. And like I said, that's very bad news when that happens. So you'll hear that word thrown around a lot, metastasize. We hope to catch it before that point, if we can. Okay, any question on those terms before we move on? I just kind of wanted to familiarize you with a lot of the terms that you commonly hear referred to in cancer circles. Now, getting back to the basic etiology of cancer, like I said, it is the second leading cause of death in the United States. To think about it, COVID might be changing these statistics a little bit, but I think COVID's become like number 3, but they may be moving into number 2 for this year anyway. But in general, in non-COVID years, the leading cause of death is cardiac disease, heart disease. The second leading cause of death is cancer. One in every 2 men at some point will develop cancer, and 1 in every 3 women. Now, you got to consider that's also includes such things as skin cancer and things like basal cell carcinoma. There again, carcinoma, there's that term again. A basal cell carcinoma is a very, very slow moving cancer, and usually it will not metastasize. It's more of a benign type cancer. And usually people just get that cut off. I know I'm getting them cut off of me right now, in fact. So that one you're not too worried about. But then there's other forms that more like a spider angioma that spread rapidly, and those are the ones that that scare you. The most common killer is lung cancer. And the most common cause of lung cancer is smoking.
Smoking.
I can have smoking.
I
Oh,
knew somebody out there would get it. Yeah, there you go. Smoking. Smoking causes lung cancer. But we all know that, right? We all know that. We're going to talk more about risk factors for cancer as we go along. In the men, the most common cancers are prostate, lung, and colon cancer. Only men have prostates, so of course only men will get prostate cancer. Lung cancer, then again, the most common cause of cancer, so of course that's going to infect both men and women. And colon cancer. Now, this is why when you hit 50 or 55, I think it is, they want you to go in for a colonoscopy. Well, they have a new test right now, which basically you just take home and you test your stool. And if that comes back clear, then you don't have to go in for a colonoscopy. But colonoscopies up until the present have been extremely important, because if we catch those little cancerous polyps right off the bat, we cut them out and everything's happy. Once it begins to spread or metastasize, it's over. So there was a strong, strong emphasis. If you're over 55, get in there and get that colonoscopy. The new test, I think they call it FIT test, which is kind of ironic because we also call it FIT test for the mask. But I think it was called a FIT test that measures looks at your stool. Now, a common cancer in women, of course, is breast cancer. Men can get breast cancer, but it's extremely rare. And this, again, why women get mammograms. Now, for the men, the prostate, that's the PSA test. You go in and get your PSA tested. But most men, especially when you get into your 50s and 60s, you're going in for blood tests anyway. So they just add the PSA test to it and look at it. Now, when that number, the PSA number, starts to go up, it means you are at risk for prostate cancer. Doesn't mean you have prostate cancer. But if the number starts to go up, they may look at some other things. There again, for women, I'm sure probably most of you women out there have at some point have had a mammogram. So I really don't have to tell you about that, but it's kind of a radiological method of looking at the breast and looking for lumps. There is also the just the breast exam, the palpating of the breast to look for lumps and bumps. So these are very important. I mean, these are the three big killers. Now, lung cancer, if you're not a smoker, you don't work in an area with hazardous chemicals and such like that, it may not be a big issue for you, but for everybody, especially when you get into your 50s and above, for men, prostate and colon, you got to get those checked out. For women, breast and colon, got to get those checked out. And we need to emphasize that to our clients as well. I'll run into guys that are 65, 70 years old. Nah, I never had that checked out. Well, you should. I mean, you know, a little preventative measure there can save you the agony of going through a very painful death. Moving on, damage to DNA. We're going to skip that. So contributing factors to cancer, there again, chemical agents, the most common of which is, of course, tobacco. Nicotine, this also is in tobacco for lungs, but you also find that in chewing tobacco. Now, you're not going to probably affect the lungs on the chewing tobacco, but all these people that get cancer of the neck and cancer of the mouth, that all comes from chewing tobacco. I've known, you know, I used to hang out with the cowboys back in Reno, and a lot of those guys developed tumors in their facial area because everybody chewed tobacco back there. Asbestos, hopefully it's not a problem anymore. Hopefully we've gotten rid of that, as well as pesticides and formaldehydes. These you probably have to be in a specialized area like agriculture or something to be exposed to those chemicals. I wonder if formaldehydes affect morticians. Good question, right?
Is that like a cause too? Because I did watch the cancer thing about oh no, it's that guy that was talking about the agricultural COVID thing. Is that related to maybe not?
Related to COVID?
The agricultural, I forgot that it's the other one. Remember the COVID? There was this guy that was talking, and the study was about in Southern California where agricultural.
Oh yeah. Oh, my buddy Hilbert. Yeah,
Yes.
in the COVID video.
Yes.
Yes. Now they would be. He's in a heavily agricultural area, and they probably have a lot of exposure to the pesticides. But I think maybe maybe formaldehydes is in the agricultural area too. I'm not sure. The only familiarity I have with formaldehyde is, you know, the embalming process, but I'm sure they use it other places as well. So people that make mummies, they probably got a lot of exposure to the formaldehyde. That was a joke. Areas that it affects, tobacco, of course, is going to hit the lungs. A lot of these chemicals like pesticides, formaldehydes, et cetera, well, but it gets into your body uses the liver to detoxify things that get into your body. Now I'm kind of reaching back now in your pharmacology, but for example, let's take aspirin, acetylsilic acid. Now, silic acid is a natural product. The Indians used it. It was on the bark of trees. They used that as a pain reliever. But what scientists found is when you eat salicylic acid or consume it in your stomach, the liver looks at it like a foreign object and breaks it down. So what they do is they use this little trick where they take an acetyl compound and they attach it to salicylic acid. So when it goes through your liver, the liver sees it as a foreign object. It takes that acetyl compound and removes it and thinks it's deactivated that poison. And then the salicylic acid itself will pass into your bloodstream. We do that with a lot of different kinds of drugs. Now you can inject the drug and it goes straight in your bloodstream and it's good, but there's other drugs where if you take them orally by mouth, anabolic steroids is one example of that. If you were to take testosterone cypionate orally, your liver will break it down and destroy it and it won't do anything. So they take the compound and they add a little something to it so that it breaks it down. Now, in the case of these pesticides and stuff, your liver is trying to break these compounds down, but it overwhelms the liver and the liver becomes toxic, and then that can lead to liver cancer. Same is true of the kidneys. Almost every drug you take is going to be filtered through the kidneys or through the liver. In fact, hold on just one second. These books right here, they're called Tarascon Pocket Pharmacopoeia. These are both the same book. This is just made for a smaller pocket. This is for the bigger one. But in every drug guide, you will find that at the very bottom, it says filtered through the kidney or filtered through the liver or filtered through both. So everything that goes through your body tries to detoxify. It's going to go to the liver or go to the kidneys. If you overwhelm either of those two organs, you can either destroy the organ, in this case of kidney failure, or you can actually cause cancer to develop in that organ. These are great books, by the way. I carried it when I was in the ER forever. So that is why liver and kidneys are outlined there, because these chemicals will overwhelm them. Moving on, environmental exposure, of course, skin cancer, sunlight, stay out of the sun, use sunblock. That's the problem I'm having. I was raised in California. We went to the beach every weekend. My skin got totally trashed. So now I'm paying the consequence for it. But not a big deal. They just cut it off and away you go. Radiation. Any of you who ever watched that special on Chernobyl on Netflix? Oh, scare the daylights out of you. Electromagnetic fields, I'm not so sure about that. It had to be a real strong electromagnetic field. There was the big thing for a long time there where, oh my God, they're putting in power lines near my house. I'm going to die of cancer. You know, so anyway. So that's environmental. The most common one for environmental is sunlight. use sunblock, I say as I go to the beach myself. Anyway, diet is a big one. High in fat and nitrates. Fat, meat, fatty meats. Meat can cause cancer. We have become such a heavy meat eating society, but there was a big study, a big cancer study done in China. Now, since China has a pretty controlling government, I guess, politically savvy way of putting it, if they tell you you're going to participate in a study, you're going to participate in a study. So they basically took the entire population of China and they studied cancer, and they found in areas of high meat consumption, they had much higher rates of cancer. Nitrates, hot dogs, beef jerky, all those, that's a preservative for food. Well, usually meat's a preservative for meat. So nitrates are very bad. Alcohol, liver cancer, and just general obesity. But I think obesity also kind of relates back to what kind of foods you're eating. So trying to think if there's anything else in the food category known for causing cancer, but meat's the big one that comes to mind for me. Better to lay off the red meats and stick more with the fish and chicken, turkey, things like that. That's my soapbox for the day. Viruses and bacteria. We are going to study Kaposi's sarcoma when we get to HIV next week. Very common. And there again, the virus is the HIV virus that's causing these cancers. Helicobacter, H. pylori. I can't pronounce that first one. That's why everybody calls it H. pylori. This is a stomach virus. It can cause ulcers, can also develop cancer within the stomach. Usually it can be knocked out with antibiotics though. So if you can catch it early, that's the secret there. Any questions on the contributing factors? Because you as nurses, you're the ones that are going to be telling people about this stuff. You're going to say, they're going to come in, they're going to be dark orange, like, was it George Hamilton used to use that skin stuff? Oh, okay. So my computer just did something really weird. It just like took me offline or something, but I think we're still recording and we're still doing good. So, okay, let's move on. Anybody that cannot hear me? That's kind of a silly question to ask, isn't it? Okay. Moving on, medications. Certain immunosuppressant drugs, and especially anti-cancer drugs, chemotherapy, they're very hard on the body. Can they actually cause mutations? Yeah, they can. They're just very toxic drugs. So you have to be careful with those. And immune system. This is usually related to a genetic problem. And like I said, there is a fail-safe within your cell that is supposed to catch when your RNA, when you get a defective section of RNA, your cells are supposed to catch it. In some people, that fail-safe does not operate, and it can allow cancer cells to survive and proliferate. So they say, genetically, they ask if your mother had breast cancer or things like this. There's a multitude of other factors. Taking Birth control pills, certain foods. I mean, every day in the news, you're seeing stuff says, oh, this is supposed to cause cancer. Next week, no, this doesn't really cause cancer. Coffee causes cancer. No, coffee doesn't cause cancer. So you're going to get totally inundated with this stuff as we go along. All right. The client has all the following in his health history. He drinks alcohol, he doesn't brush his teeth, he gets tonsillitis, and he chews tobacco. Oh, I just got a visual. It's really bad. Anyway, what is most likely to contribute to him getting oral cancer? Any guesses?
Chewing tobacco.
Chewing tobacco, you're right. The other stuff might cause some infections and all, but the cancer will probably come from the chewing tobacco. Moving on, here are some things that maybe your clients may need to be aware of. They came up with an acronym, CAUTION, because medicine loves acronyms. Mostly, and you can look over this, change in bowel habits. There again, if you have colon cancer, this could be a problem. An unhealing sore, I'm thinking skin cancer. Unusual bleeding, that I'm not sure if they're talking about like on the skin or internally, but any kind of unusual bleeding, you got to get it checked out. Thickening lump, breast cancer, testicular cancer. Indigestion, there again, stomach cancer. Obvious change. Now this is the big one here. When you have a mole or a wart or a skin tag or anything like that that begins to change, get it checked out, because that is really a big indication that you may have a skin cancer. And nagging cough for those who smoke or who have been exposed to lung chemicals. Other things, and this is quite often, especially in leukemia, getting headaches, weight loss, chronic pain, fatigue. You just don't feel right. It's a good time to go in and get some blood tests run. Now, if it's leukemia, you're probably the first place it'll show up will be your CBC, your white blood cell count, because leukemia affects your blood producer, your bone marrow. That's where you produce your red blood cells and your white blood cells, right? We all know this stuff. Yeah. Cancer prevention. Educate your clients, make them aware of the warning signs, the caution. You might want, now there again, you probably want to hit on those things that kind of apply to the patient. If the patient is obese, you may want to hit on dietary risks. If they come in, looking like all orange, you might want to talk to them about wearing skin block, or if they have unusual bruises or spots on their skin that look kind of questionable. They need to get in to see a dermatologist. There's a variety of cancer screening programs out there. I'm sure there's plenty that are free if your client, ever since the Affordable Care Act, all preventative medicine testing is supposed to be free, if I'm not mistaken. I don't think that's been changed. I think that's still in place. So prostate screening, mammograms, all these kind of preventative medicine things, you don't have to pay for, and emphasize that to your clients. Go to the doctor, get your physical exams, self-exams, there again, for females, breast examination, for males, testicular examination, for everybody, skin examination, and just avoid the risk factors. Don't smoke, don't lay in the sun for 5 hours at a time. Now, diagnostic procedures. How do we test for this? Well, there again, a lot of that will depend on what type of cancer we're looking for. For more of the lymphomas and the leukemias, there are some tests we can use. They're called tumor markers. We do a blood test. We can look for those particular. First thing, of course, we'll look at the CBC. Why? Because we give CBCs to everybody. CMP and CBC. Everybody gets a CBC. So we can look at that and we see if their white blood cell count is low. That's going to be a big indicator right there. Or if it's out of whack in any way, then we move on to do more specific tests. X-ray imaging is good for especially lung cancer. I mean, lung cancer just shows up bright as day on a chest X-ray. There's other types of imaging when we talk about a KUB, kidneys, ureters, and bladder. We call it KUB. Basically, it's an X-ray of your abdomen. We might use contrast like barium for that area if we're looking for stomach cancer, intestinal cancer, colon cancer. CT scans are good for tumors. Any kind of lumps or anything that are where they're not supposed to be. CT of the head for head tumors. You can scan the lung, you can scan bones. You can scan anywhere. But they're looking, CT is mostly looking for tumors. MRI is the same as a CT, only more specific. It's looking for hot spots. Ultrasounds are good for the abdomen in that area. There again, the KUB area. The radiologist may see something suspicious on the KUB X-ray and move them on to an ultrasound, which gives a little more specific information. Fluoroscopy, good for swallow studies. Fluoroscopy, a fluoroscope basically is just a moving X-ray. It's an X-ray that you can use. Well, for example, we use fluoroscopy in the cath lab. So when we shoot the dye into the heart and it shows up on the fluoroscope, we actually see the heart beating at the time, whereas an X-ray is just a one-time photograph. It's like the difference between a picture and a video. Biopsy, that's especially applicable to leukemia. We do a bone biopsy, go in, take a look at the bone marrow, look for tumor markers. And endoscopy is when they go down your throat, they're looking at your stomach, or colonoscopy is when they're looking in your intestines. A variety of ways, depending on what type of cancer they're looking for. Nurse is conducting a skin assessment on a client. Which of the following characteristics of a mole warrants further examination by the physician? This is interesting. Located on the neck.
Shape?
What's that?
Irregular shape?
Irregular shape is correct. If you have just a little round mole, everybody's got those. They're all over the body, right? But when they start to kind of do irregular shapes, they're called nevis. That can be a bad sign. So we need to get into the dermatologist and get that checked out. It's really kind of funny, and I got to relate this experience. But I grew up in California in the sun a lot. I got a lot of freckles. I got a lot of moles and different stuff on my skin, on my body, and stuff that I think is like, oh, I'm really worried about this, doc. The dermatologist looks at and goes, no, that's nothing. And then other stuff like just a little red spot on the arm that I go, I don't know what that is. They get all worried about. So I guess the point of this is you never really know what is important and what isn't, because the spots that I thought on my skin that I thought were nothing were the ones that turned out to be basal cell carcinoma. Whereas the other ones, like the mole that wasn't quite right, the dermatologist looked at and said, yeah, that's fine. So don't try to self-diagnose. Just if you got something on your skin, you're not sure what it is, get into the doctor and let them take a look at it. Okay, skin cancer stages. We've heard this a lot. We've heard, oh yeah, oh Joyce, she is now in stage 4. We see it in movies, we hear it on the street all the time. Oh, this is the stages that they're talking about when they say that. And usually, people don't even know what stage 4 is. All they know is it's really bad, right? Oh, stage 4 cancer. Oh, I don't know what it is, but it sounds horrible. But this is really what they're talking about right here. 0 is basically just when they find a cell. And hopefully in stage 0, they can just cut it out and get rid of it, and you never have to worry about it again. Now, that being said, quite often, like we'll talk about the skin cancer again, basal cell carcinoma, very slow moving, benign. they'll usually cut it out or use a chemotherapy type chemical on it to kill it, and you're fine. But if it's a, I'm trying to think of what the other one is, but more of a spider angioma or more of a spreading, fast moving one, what they might do is they might cut it out, but then they might also put you on chemotherapy for a while just to make sure that it didn't spread. So depending on what type of cancer it is, they may or may not put you on more of a prophylactic type chemotherapy treatment just to make sure we kill it off and make sure it doesn't spread. So that's why sometimes you'll see, well, oh, they took the tumor out and they're not worried about it. Or they took the tumor out, but they're still doing radiation. They're still doing chemotherapy. It's going to depend on what type of cancer cell they're dealing with. Now, stage 1 and 2 and 3, these are the stages where it's beginning to spread to other organs. And there again, like I said, if it spread to the lymph system or it spreads to the blood system, as in the case of leukemia, that is really, really bad. If it just spreads to an adjoining organ, well, you know, hopefully, like say that spread to the kidney. Well, we can get rid of a kidney. You only need one kidney. So that's not quite as bad. But once it gets into one of those circulatory systems, that's a really bad thing. And then stage 4, that's the reason everybody talks about stage 4 is because that's where it has metastasized to other parts of the body. And usually at that point, it means it's spreading uncontrolled and not a whole lot they could do about it. Now, that being said, there is there is a lot of good development going on in the stage of, my boss is looking at me through the window. There is a lot of good development going on in chemotherapy now these days. And I'm going to talk a little bit more about the drugs here in a moment, but things have really, really progressed a lot. We've come a long way in fighting cancer. There we go. Methods for treatment. Now, we all know there's surgery, right? You got something, you got a lump, say on the breast, they can do a mastectomy. A lumpectomy is just where they take and cut out the lump. A mastectomy is where they take out the entire gland. In the case of women, they may actually do a breast removal. And what I thought was nice about the VA was if they do a mastectomy, they also pay for a prosthetic to be put back in its place as well, which I thought was, well, that's pretty nice for the government. Tumor incision, well, that's like if you're getting it cut off your skin right there. But we're mostly familiar with like mastectomy and lumpectomy. For example, brain tumor, go in, cut open, cut the lump out. I'm not sure what they mean by prophylactic surgery. Palliative, these are just measures for relieving the symptoms. Now, this may be a person in stage 4 where we can't really do much for them at this point. So we want to relieve the symptoms that are being caused by the cancer. Nerve blocks is a way of controlling pain by stopping the signal in the nerve channel going up through the spine. Thoracentesis, paracentesis, those are just methods for getting fluid out of, say, the heart and lung areas. Like I said, reconstructive surgery, that a good example of that is prosthetic breast in the case of a mastectomy. Mohs surgery. Now, some doctor named Mohs cut a layer of skin off and decided to name it after himself. So the saving, there again, the basal cell carcinoma on the skin, just cutting it off. Or you can take a chemo drug paste and apply it to the area, which will also kill it. Either one works fine. There's a variety of different types of surgeries. Now, another one we're all pretty much familiar with is radiation. You know, surgery, radiation, chemotherapy. Those are the big things. Those are the 3 ones that we're mostly familiar with, right? I think we've all heard about those. Radiation is tough. Radiation is brutal. There's external radiation. That's where we actually put the person into the machine and shoot radiation. You've seen that a lot, especially in places like thyroid cancer, mouth cancer, things like this. They just basically take that X-ray machine and they kill the cells. The problem is you're killing good cells and bad cells. You're basically killing everything under the target area. And there are some side effects to that, but I'll talk about that in a minute. Internal therapy or internal radiation therapy is where we actually take a radioactive item and implant it next to the organ or tissue that is cancerous, and it works on killing the surrounding tissue. There again, it kills everything in its wake, good tissue and bad tissue. Hopefully the good tissue, your body just regenerates it, but hopefully it kills off all the bad tissue too. Radiation side effects. There are a ton of them. Alopecia is one we're very familiar with. That's where you lose your hair. Desquamation, that's the skin. And the reason I'm pointing these out, I'll tell you here in just a moment. Stomitis in the stomach. The way that chemotherapy works are, well, that actually applies more to chemotherapy, but what we're trying to do is kill a cell that's replicating rapidly. Unfortunately, though, there's a lot of other cells in our body that replicate rapidly because they're supposed to. Your fingernails, your hair, etc., your skin. So when we use chemotherapy, which I'll talk about here in a moment, it's targeting those cells that are replicating rapidly, and that's why you lose your hair, because it's targeting all the cells that replicate rapidly. So, so that's why I just thought I'd throw that in. So that's why you lose your hair when you're on chemotherapy. Nausea is a big deal. Fatigue is a big deal in radiation therapy. These people go through a lot. So, and here's some other things that radiation can do, depending on what area of the body is being irradiated. This is where, like with bone, the bone marrow is being irradiated. It's going to affect your white blood cell count, your red blood cell count, your platelets. It's going to affect everything that's being manufactured in the bone, the body. Some safety precautions when it comes to radiation. 3 big things: distance, shielding, and time. Those are the 3 big things when it comes to radiation. You want distance, you want to minimize the amount of time you're there, and you want to wear shielding. Now, those of you that did the discussion questions, which probably should be all of you, you know that there were some precautions you take for somebody who has internally implanted radiation device, right? People keep their distance, limit the time in the room, and if you do have to go in and spend time with the room, you wear the lead shielding. Anything that's contaminated by the radiation stuff has to be treated in a very special way. They'll usually have a different color bag. You don't throw them in the red bag for biohazard. They have a different color bag for chemotherapy and radiation stuff. I think it's blue. Can't remember. Question: client has frequent nausea, vomiting following radiation to the abdomen. Ooh. What appropriate intervention is a nurse to use? Antibiotic before meals. Is antibiotic going to help with nausea? No. Monitor fluid intake and output. Might be a good answer. Serve the food while hot. Not going to help any. Music and conversation is nice, but there's a more effective one. Anybody know which one that is? Fluid intake output. Fluid imbalance can result in nausea and vomiting. A good example of this is a hangover. If anybody who has ever had a hangover, I don't know who that would be, you get dehydrated. And when you get dehydrated, you get nauseated. So you have to make sure these people are drinking enough fluid. Keep a close eye on their inputs and their outputs. Moving on. Okay, the third one, chemotherapy. these drugs basically interfere with the RNA DNA synthesis. There again, like I said before, these drugs are designed to target and kill the rapidly replicating cells. There's a variety of ways to take chemotherapy. Most people, when we send them home on long-term chemotherapy, we will either put a PICC line in their arm, which is a very long IV that goes into their heart, or a Hickman. This is that little device that below the skin, where you poke the needle through and into the skin. Okay, you guys, okay, it's the seniors that I showed this to, but when in so later clinicals, we have a mannequin that has a Hickman, and we'll show you how that works. We don't send them home with just regular IVs, because regular IVs are short, they're small, they fall out real easy. So we always take the hospital IVs we take out and we replace it with something that lasts longer. But you can also take oral chemical shots just about everywhere you can. There again, the skin cancer, you use a topical cream on that. So there's a variety of ways of getting the chemotherapy drug into the person's system. Side effects: nausea, vomiting, stomatitis, which is inflammation in the intestinal area, the digestive tract, alopecia, loss of hair, myelosuppression, and fatigue. Myelosuppression, and I just drew a blank on that one completely. Anybody remember what myelosuppression is? I think I was talking about the bone marrow there, where it's suppressing your white cell, red cell blood production, which would give you anemia, which is another common side effect. There again, hair, intestines, stomach lining, all these are cells that replicate rapidly in your body because they're supposed to. Your intestinal cells replace, I think, like every 24 hours or something, really rapid replacement. So since they're rapidly replacing, the chemotherapy thinks they're cancer and kills them. So that's what causes a lot of the nausea in your intestinal tract, causes your hair to fall out. So any cells in your body that replicate rapidly, the chemotherapy is going to have an impact on it. Because of the nausea, eat small, frequent meals, because it helps reduce the nausea. Plus, frequent meals keeps food in their stomach, which helps relieve some of the nausea. You're at risk for gout. We talked about gout a few weeks ago. Increase the food intake. There again, you want to watch and make sure they don't get dehydrated, and excessive weight loss. These people are nauseated. They don't want to drink. They don't want to eat. They just sit there and they're miserable. And it's really sad, but they have to eat. They have to eat and they have to drink. So you got to encourage them to do that. Find out what food they really, really like and just try to get that from the cafeteria for them. Moving on. Stem cell. We've all heard a lot about stem cells. There's been a lot of controversy about stem cells. But basically what you're doing is you're trying to replace that part of the bone marrow destroyed by the cancer or the cancer treatment. And by doing that, stem cells are like the ultimate cell that can evolve into anything. How am I doing for time? Oh, okay, I think we're almost done. Stem cells are very controversial because we were using stem cells from aborted fetuses for a lot of cancer research. And there were certain political parties out there or religious parties who had issue with that. And that's why stem cell was such a controversial thing. This is not that stem cell. This stem cell either comes from the person's self, where you draw stem cells out of your own body and freeze them and save them, you know, from areas of the body that don't have the cancer, obviously. Or you get a donor stem cell. Another person who is compatible with you can donate stem cells. There again, you might have to take some immunosuppressant drugs because your body may try to reject those stem cells. Synthetic, you don't have the rejection of the tissue with the synthetic or syngenetic, I'm sorry, not synthetic, syngenetic, identical twin, if you're lucky enough to have an identical twin. Doesn't happen quite often. Okay, we're just going to move into nursing interventions and then we'll wrap this up. There again, encourage the patient to eat protein and calories. I would say protein and carbs. They need the energy. They're tired all the time. They're beat up. It's like they've gone 3 rounds with Mike Tyson. Small meals, but encourage them to eat, encourage them to drink. So a good nursing diagnosis there is going to be imbalanced nutrition. Taking antiemetics, taking things like Zofran before a meal. Try to get an antiemetic into them before they eat. That'll help reduce the nausea. And disturbed body images is another nursing diagnosis. There again, that has because they lose weight because of the cancer treatment and they lose their hair. We associate a lot of our self-image with our hair, and we get to be pale and we get drawn, and you don't feel pretty, trust me. Caring for the terminally ill. These are the people that hit the stage 4. They're not going to get better. They'll eventually move to hospice, and we just take care of them as best we can. Try to get them to monitor themselves on activity so they don't wear themselves out. They'll usually have some type of pain medication, usually morphine in high doses to help treat the pain. And obviously, you're not going to be worried about addiction at this point, obviously. Make sure they get adequate fluid and nutrition. Keep them warm and dry. As they lose body fat, they're going to get cold easily. Odors, because of their nausea and because of what's going on, odors can really, things can really smell bad to them. And anything you can do to help them to maintain their dignity. Any questions on this? Are we ready to wrap it up? Got to do a little hospice back when I was nursing. It's a different experience, but it's not all sad. I mean, you feel like you're serving a good purpose when you're a hospice nurse. You're serving a good function. So that may be something some of you may want to explore in the future. Any questions before I turn the recording off?
Can LPNs be hospice nurses?
Say again?
Can LPNs be a hospice nurse, or do you have to be the full RN?
I don't see why they can't be. I really don't. In fact, I would see that as a very, very good role for LPNs.
I just asked one of the nurses I work with last night who came from Hospice House, which is a Franciscan hospice facility. And she said neither home hospice for Franciscan, neither home hospice or hospice house has LPNs currently.
Oh.
But they used to.
To be honest with you, I think that would depend on the organization. Just like there's no LPNs at St. Joe's, but there are LPNs at Tacoma General, and they're both hospitals. So I think it's just going to be by institution. Any other questions? Also,
Hey, Brett.